Good afternoon, Rotarians. Welcome. We're so glad that you're here. Love all the conversations and people being able to speak with each other. Welcome to those of you who are on Zoom as well. And thank you very much, Marita Wade, for being our hostess with our people who are joining us today via Zoom. We will begin with the national anthem with President-elect Steve King, followed by the invocation and four-way test with Molly Rydell. Can you see by the dawn's early light what so proudly we hail at the twilight's last gleaming, whose broad stripes and bright stars through the perilous fight o'er the ramparts we watched were so gallantly streaming, and the rocket's red glare, the bombs bursting in air, gave proof through the night that our flag was still there. Oh, say does that star-spangled banner yet wave o'er the land of the free and the home of the brave? Thank you very much, Steve King and Janet Metzler. Let's give Janet a round of applause on the piano.
Good afternoon, everyone. Please join me in a brief prayer. Almighty Father, thank you for all of the gifts that you have given us. We are so very grateful for the camaraderie that we enjoy. Please continue to guide us and help us with all the decisions that we make for our communities and for people that are less fortunate than us around the world. We thank you for the lunch we're about to enjoy, and to our speaker, Dr. Jack Kereiakes with Christ Hospital today. Dr. Dean Keriakes, I beg your pardon. And again, thank you for all the blessings. Amen. And now for the four-way test of the things we think, say, and do. Is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned? Thank you. Oh, that was so lame. That's great.
Great. Thank you so much, Molly, on short notice. We appreciate that. Next, we will have the Bob Bowling Memorial. Bob was a wonderful member of our club who's passed away, and past president Ron Ott would give the words for Bob Bowling. Would you please stand for the memorial? Ron?
Join with me in celebrating the life of Robert E. Bowling. Robert passed at age 92. He was born on January 4th of 1930 in Wilmette, Illinois. He moved to Cincinnati in 1937. He was a devoted family man, businessman, and community leader. He was a proud graduate of Withrow High School, the University of Cincinnati, where he got his BBA, and Xavier University, where he got his MBA. Immediately upon graduation from UC, he served 2 years in the Army during the Korean War. and achieved the rank of Master Sergeant and was awarded a Bronze Star for meritorious service. He was a member of Pi Kappa Alpha fraternity. He served on the board of the Rotary Club. He was a member of Pi Kappa Alpha fraternity. He served on the board of the Rotary Club, and he was a Paul Harris Fellow. During his 58-year membership, serving twice as a Cincinnati chapter president, he continued a family tradition as a member of the Sons of the American Revolution. His long career included working purchasing and sales at Baldwin Piano, Kenner Toys, and Acker's Packaging. He was a 62-year member of Makatiwa Country Club. He actually was there long enough that he didn't have to pay dues anymore. His long career at Makatiwa, he actually had a hole-in-one on number 18, which is a tough hole. When I hit number 18, I either put it on the hill or put it in the parking lot. In 1959, he joined Church of the Redeemer, where he devoted 35 years as a volunteer yard man, raking leaves and picking up weeds. He was survived by his daughter, Ellen, who's right here, and her husband, Doug, who he and I had a working relationship, so I was glad to have Ellen into the working family. They have two step-grandsons, Craig and Stephen Zemke, and a step-great-grandchildren, Douglas, Lillian, and Henry. He was preceded in death by his parents, Clem and Augusta Bowley, and his wife of 60-plus years, Jane, and the family thanks the folks for having the time to acknowledge Bob's participation in Rotary. He was a devoted bowler, and we bowled in these crummy little alleys, 6 alleys in the basement of Makatiwa Country Club. And Bob was our sponsor. Well, we had the place to ourselves. And we had our own private bartender. And we also was the guy who repaired the alleys. Well, I remember bowling against Bob, and invariably every time his turn was to bowl, the alleys would break. And there would be a lot of mumbling and grumbling about what crummy alleys, but we never moved out until we had the incident. And that was reason for all of us to move out. Bob was an avid bowler. He enjoyed it a lot, and he enjoyed the company of fellow bowlers. So here's to Bob Bowling. We acknowledge your existence. We acknowledge your time together. We acknowledge your friendship. So please take a moment and pause and say a little prayer for Bob. Thank you very much. All right, everybody, seats.
Thank you very much, Ron. And thank you, Ellen and Jack, for being here as well. Next, we will have our Sergeant at Arms, Uda Papke. She will introduce our guest today. Following Uda will be Mike LaValle and Kelly Crow. They will give us an update on Camp Allen's 100th year. Really excited that Uda is here to introduce our guests. Edyth just recently celebrated her 25th year membership of our club, and I especially am thankful to Edyth because she's part of the reason why I'm a member of this club. So thank you for the invitation, Edyth.
No, it's a pleasure, and thank you very much. We have Carol Roundtree here as a guest from Kelly Collison. If you would please stand, yes. And we also have Rodney Parks from the UC Foundation, who is also a guest of Kelly. I'm thinking since we have quite a few, please just stand and we'll applaud after we're done. Thank you. Now, I also have 3 names here. I don't know if you came later. Paul Williams, are you here? Justin Theriot, Mark Goodman. Okay, then I know Beverly Pearson is here. She is a guest of Melinda Kelly's. We also have Sarah Portman, who is a guest of Tasha Stapleton. We also have Gloria Jordan, who is a guest of Melinda Kelly, as well as Antonio Conley, who is also a guest of Melinda's. We have Josh Fogel. He is a guest of Jack Scott. And then last but not least, my own youngest grandson, Jake Westrick, who is a guest of ours today. Thank you.
Good afternoon, everyone. I'm here to talk briefly about our Camp Allen Minute this morning, or this afternoon. I'm going to bring Kelly Crow up here in a second. But the last time I was up here a couple weeks ago, we ended in 1960. And that was an important time because in my research, that was the first time it was ever acknowledged that we were servicing mentally handicapped kids at the camp. So since 1960, there wasn't a whole lot that happened. We put up a new roof on a building. We built a new cabin, built some new bunk beds. I think it said we ordered put in 100 new mattresses. So a lot of stuff was going on to keep the camp alive. And in 1964, it was a busy place because there was over 1,000 people that attended Camp Allen, Boy Scouts, our own folks, or whatever it might be. But it was over 1,000 that attended that year. So that gets us up to 1970 for the most part. And the reason that's an important milestone is that's the year that Cincinnati Rotary and Stepping Stones became partners in Camp Allen. So this was a great joint adventure, and that's why I'm going to have Kelly come up. And she's going to explain why that's been such a great cooperation between the two and why the two organizations went together so well. So, Kelly.
Oh, thank you, Mike, and it's a pleasure to be here to talk with you about Camp Allen. I know we've went through so many decades already, but as Mike said, this is a really important one, and I'm just going to say a few words, but actually just made, well, I didn't, but someone in our office made a little video that I think will better illustrate, but this is a key decade because it's when sort of the formality of the two organizations came together. And when Mike and I were talking in preparation for today, we were talking about why did it make so much sense for, Stepping Stones and Rotary to partner? And I think as it relates to Camp Allen, the one thing that's so key to know is it was and it remains the only location that Stepping Stones has that has lodging so that we can do overnight programming. And so, to this day, even though we have multiple campuses, that's the one place that people can get a respite. And for anyone who has a loved one with a disability or has served as a caregiver, or if you know anyone that does, that respite is so key, not just for the individual that we're serving, but just really critical for the family or the caregiver or the parents to have that break. Probably the most heartwarming stories I hear are in regards to that from the family about how important it is for the individual's independence, but also what the family or the caregiver is able to do during that time. So to this day, in the fall, winter, spring, we have respite on Friday through Sunday, so 2 nights, and then as we're in the busy summer season right now, it's 9 weeks of overnight camp for about 5 nights at a time. So as Mike said, that was, kind of the important decade, and obviously Rotary continues to, of course, own the land as they did then, but Stepping Stone sort of operates it, and but Rotary is such a key financial supporter, but also, of course, the volunteer efforts started at that time and have continued since then. So I think the relationship between the two was just very strengthened by matching up something that Stepping Stones was not able to offer, and then that Rotary was. So it is a privilege, but I think the video will do a little bit more justice than my words.
Thank you very much, Mike, and thank you, Kelly. Before we get to our announcements, I'd like for Before Autry and Tony Autry to please come forward. As you all know, in our Rotary Club, we have 3 international projects. We have the Uganda Sun Project, and we had the person who was over that project along with Deborah Schultz to actually be at our club a few months ago. And we have the project in Ghana that Tony and Before Autry are sponsoring and are over that program, and they're boots on the ground. And we also have the project in Madagascar that Dr. Hux and Ariel Miller facilitates a lot of our communication there. We're really excited this year that we have one of our members who's currently in Ghana right now, who is Mary Smiley. And we're really excited to have her there. She's there on a vacation, but she's also going to visit our schools that are in Ghana. And we want to just bring forth Tony and Before Autry for commissioning. We have President-elect Steve King, who's up here as well. Before will be leaving to go to Ghana in maybe about 4 or 5 days. And we'll have Tony and Before to share just a little bit about what they will be doing, as they will be boots on the ground for Club 17. They're in Ghana, and then President-elect Steve King will be joining Before there as well. So we want to just do a commissioning and send off for Before and keep him in our thoughts and prayers.
Yes, thank you. Thank you so much. We are so excited and delighted that you have sponsored this program for the World Affairs Committee for the Ghana School Project. And it will enable us to service 4 schools with textbooks, dual desks, painting, the interior, the exterior, and other items, teacher's desk, so many wonderful things, and 15,000 pairs of sunglasses. We'll also be taking along with us 250 pounds of medical supplies. Thanks to Hux for introducing us to that organization in Kentucky a few years ago. And we are even more so delighted that our president-elect and William and Claire will also be going to Ghana with my husband.
Tony and Before, I just want to say thank you for inviting us. I think I'm bringing about 250 pounds of teenagers with me. I'm hoping that we can teach them to be people of action like Tony and Before here. You know, I have never traveled to Africa before, and I'm just delighted to have a chance to accompany Bafour and visit some of the schools that we're going to be impacting with the donations that raised by the funds at the World Affairs Committee. Bafour?
Yeah, we are excited for this project, and we're looking forward to go and help the kids as much as we can. And we're looking for great things to come. We'll try to send more information and more pictures and a lot of things that we'll be doing. We'll bring it back. And we also thank Rotary for, doing this project and making sure, I guess about 3 years in the running now. And so we got to clap for ourselves for, getting this project going.
Right. So thank you very much. We really appreciate it. We wish you safe travels. We wanted to make sure we got that in. It wasn't on the agenda, but it was very, very important. We wanted to make sure they had our support, and we look forward to the pictures coming back from the trip. We have some announcements today. We have some birthdays today. Christy will put those birthdays up on the screen. If any one of the birthday Rotarians are here, if you would please stand. Rick Flynn, June 14th, 15th, you see John Frank. 16th, Eric Petway, Ken Coggeshall. June 17th, Brad Winstrup. And June 19th, Bob Will. Let's give our Rotarians a round of applause. For our announcements this week, we will go ahead and do Split the Pot. Our winner of Split the Pot 2 weeks ago is here. Would you please stand, Don? Don won like $1,800 or something like that. And so he said he made a lot of friends after that. Just kidding. All right, so we'll do Split the Pot today. And remember, we will be drawing for the Queen of Hearts. We will ask Dr. Dean Keriakes to pull the winning number. Everyone is eligible for the first ticket draw. And that first ticket draw's winner is $48. And the accumulating pot, starting over again, is we're at $99. No, I'm sorry, the rolling pot is at $48. So $48 is the first ticket draw. The accumulating pot is $99. I think it's a little mixed up on my sheet. The winning number is 4023. 4023, we have a winner. And he will be drawing for the Queen of Hearts. And no, I'm sorry. Oh, he donated the $48 back to the club. Let's give him a round of applause, and thank you so very much, Mark. We really appreciate that. Thanks, Owen, for sharing that. Christy made an announcement last week about dues and billing, and most of you should have gotten that notice by now. If you haven't, please see the office today. As you know, we are cutting down on our announcements here from the podium as much as we can so that we can leave time for the speaker, and we're really looking forward to our speaker today. Let us also congratulate at this time Rotarian Becky McGilligan on her recent engagement. So welcome Becky and Dave on their new engagement, Dr. Becky. There will be no YP committee meeting today. However, we will have euchre coming up, and Jeff Weir is here. Where's Jeff? Jeff is here. He's our coordinator, and you know, euchre meets each month on the fourth Tuesday. So June 28th is that date, and the euchre club will be meeting at the home of Camille Scherzinger. 6:30 is the time for registration, and the first deal is 7 o'clock. All levels of experience are invited to attend, so if you're not familiar with euchre, just come. They'll be glad to help introduce you to the game. And always, please bring a snack or a sweet treat to share with others. And I'm not that familiar with euchre, but they said bring your quarters in case you are euchred. So you would know what that is. So thank you very much, Jeff, and thank you, Camille, for hosting euchre. And then we have 2 meetings this afternoon. We have our board meeting, which will be in the Julep Room. If we could be there pretty expeditiously, we have a long day with the board because we have a board meeting after that. After our Rotary board meeting, we have another board dinner this evening. So if we can make sure we get there expeditiously, that would be greatly appreciated. And again, the young professionals will not be meeting today. Next week, our meeting speaker will be Mayor of Cincinnati, Aftab Pureval. So please be here next week for our meeting. Now, those are the announcements. As you can see, they get pretty lengthy, so we're trying to cut those down. We are excited about our program today. We have Dr. Dean Keriakes, and we have past President Jack Scott, who will introduce Dr. Dean Keriakes.
Thank you, President Melinda. Hasn't President Melinda done a great job this year? I know she still has a couple weeks. So proud to have the leadership that we have here at Rotary. Good afternoon, Rotarians and guests. Originally, Al Conscious was to make the introduction, but he had a conflict. He has been suffering with a shoulder problem, which he found out was his humerus. Funny something like that should happen to Al. So he has been reduced to light activity, no tennis or golf, but light drinking is permitted in sandals on the beach somewhere. So I've been assigned the duty, and it's my pleasure to do this. I'm pleased to be able to present to you Dr. Dean Keriakes, and Dean is what I consider to be one of Cincinnati's 7 wonders. Just such a bright light. When you look up on the hill, you think about all the really great physicians, and you can't help but think of Dr. Keriakes. Dr. Keriakes was born in Louisville, but spent his formative years here in Cincinnati, where he went to school at Indian Hills. He was quite an athlete and was very good at academics as well. He is the grandson of Greek immigrants and the son of a noted radiation physicist who actually pioneered radiation dosimetry. He graduated from UC as a valedictorian, which says a lot there. But they traveled to San Francisco, where he studied at the University of California and the San Francisco Heart Institute. He returned to Cincinnati and began his long career at Christ Hospital in 1985, where he has steadily rose to his current position as president and medical director of the Christ Hospital Heart and Vascular Institute. He also serves as the medical director of the Carl and Edyth Lindner Center for Research and Education at Christ Hospital. He has served as the investigator or the co-investigator on more than 1,100 trials on most of the interventional technologies that have taken place over the last 2 decades. He has published over 700 journal articles, abstract, and book chapters. He has also performed more than 25,000 catheterizations. He serves on several editorial boards with many of the medical journals and is an advisor to many of the pharmaceutical companies. He has received too many awards and honors for me to name. He met his wife, Anne, in San Francisco, and together, residing in Indian Hills, they have 4 grown children. I'm going to ask at this point in time, how many of you out there have been a patient of Dr. Keriakes' group? Oh, wow, unbelievable. That's cool. There are a lot of people that are alive because of that man. With no further ado, I'm going to let Dr. Keriakes tell you and tell us about what all is taking place as far as cardiology is concerned. There you are. You snuck up on me.
Oh, thanks. I think I'm going to work from up there. That's where I know
That would be good. Thank you.
Listen, I can't thank you enough for such an incredible and gracious introduction. I'm going to talk about, and several of you have come up and said, hey, thank you for coming here and talking, and I want to tell you point blank, this is my job. I've been told so many times, and most recently by a prominent member of the community, when I talked about what we do at the Christ Hospital Heart and Vascular Institute and the Carl and Edyth Lindner Center for Research and Education, this person who all of you would know says, how come we didn't know that? And I've often said that, I'll be honest, we're the best kept secret in the Midwest, if not the country, but I'll let you be the decide on that after you see what we do. 13 different times the first use of a novel medical device or new drug in the world in a human being has been done at Christ Hospital through the Lindner Center. This includes such notables as the first time TPA, tissue plasminogen activator, clot dissolving drug was used to treat a stroke, which revolutionized stroke therapy worldwide. Tom Bright at the university was our principal investigator. First patient is treated at Christ. The first time a cobalt chromium coronary artery stent was placed in a human being. And any of you that have stents in, I can tell you it's not stainless steel in this era. This was the first step to move away from stainless steel to create devices with thinner struts, greater radial strength, improve the safety and effectiveness of coronary artery stenting, revolutionize coronary stenting. First time, Christ Hospital. 31 times and counting, the first use of a novel medical drug or device in the state of Ohio. In the United States, I'm sorry. Actually, 31 times in the United States came through the Lindner Center. Things you take for granted, like an MRI-compatible pacemaker, everybody's got them now, right? First time in the U.S. at Christ Hospital. We incorporate clinical research into clinical practice. These things are intertwined so that we integrate all the buzzwords in current medicine. Now, many of you may be affiliated with hospital institutions or medical care institutions, but you know these buzzwords well. Innovation and excellence in clinical practice that provides guideline-compliant, quality-assured, protocol-driven algorithms for patient care that reins in outliers for bad outcomes, also for cost, and it defrays the cost of care through discounted free drugs and devices when they're investigational. It provides nurse case management, another buzzword, to the patient at no cost or to the payer. And last but not least, it provides access to therapies years in advance of commercial availability. The average device cycle, so that you know, from the first time we test a device at Christ to when the FDA approves it is 3 years. So we have many treatment options that others do not. The preeminence of the Lindner Clinical Research Center on a national level with 1,600 trials, 160 active trials as we speak, and being rated by outside organizations like Medtronic Corporation, which is a world leader in medical device development, as being the top clinical research center in the country that they work with on successive years, has allowed us to recruit an individual like Tim Henry, the blonde guy in the picture, Chief of Cardiology at Cedars-Sinai in Los Angeles, a top 3 program in the United States, President of the Society of Cardiac Angiography and Intervention, one of the main components of the American College of Cardiology, and now is the Lindner Family Endowed Chair in Clinical Research as the Medical Director of the Carl and Edyth Lindner Center. How do we pick research? Well, I think you got to look at the needs of society, the needs of our community, and these are the top 5 Medicare cardiac diagnoses. We're going to come back to the top here, congestive heart failure, which is far and away the leader, in a moment. I won't have time to touch on atrial fibrillation, another significant issue that will affect many of you or your families. And I'm going to focus on an area where we have an explosive amount of technology, and that is the 2 most common valvular heart diseases today are aortic valve stenosis and mitral valve regurgitation. You're looking down on an aortic valve. The aorta's been transected. It's a 3-leaflet structure. You can see it has what looks like a peace sign or a Mercedes-Benz sign, depending on your perspective. These leaflets are not paper thin. They don't look like cellophane. They are very calcified, nodular calcium, very thick. They become immobile, and this obstructs blood outflow from the left ventricle. The heart has to work 2 and 3 times harder. 12% of people over the age of 75 have some degree of aortic stenosis. Think about that population. A third of these will be severe. The typical approach, and I know this is lunch, but this is a couple of our guys with the sternal retractors. You're looking down on the heart. On April 16th, 2002, a friend, Elaine Cribier, in Rouen, France, and I'm going to go back there, he changed the world. This is actually an angiogram from the very first transcatheter aortic valve replacement. The concept, replace a heart valve without open heart surgery. This looks like a made-in-your-garage stainless steel stent device. You look at the calcium here. We're going to come back to that in a second. And there's a cow valve sewn inside of this. It really worked. This is the transesophageal echo showing the leaflet work. This is a 57-year-old Frenchman dying of heart failure who had a bicuspid aortic valve. We've gone through 4 generations of these technologies. I know you've all seen these or heard about this. TAVR, TAVR, Bill Cunningham calls it TAVR. This is a retrograde from the aorta. We go in the femoral artery. It's mounted on a stent. This is the #1 valve in the United States today, probably 70% or more of market share. And we're one of the first 10 centers to test the new SAPIEN 4, which is the next generation. Each one is iteratively improved. We put it on a balloon, and patients want to know, how does that go in? Well, do you stop the heart? Well, we actually pace the heart at 160 beats per minute for about 5 to 8 seconds. That's all it takes. If you think about it, the heart doesn't have time to fill, so it quivers. There's no flow, and we're able to go up with the balloon, embed this new valve. Patients say, what happened to my valve? Well, it gets crushed like a trash compactor and circularized by the new valve. And that grit helps hold it in place. If you think of this as being almost a Velcro cuff here, it helps hold it in place, sutureless retention. If we tried to do this while the heart was beating, theoretically the valve can be popped out like a champagne cork, and that would be a disaster. So we effectively stopped the heart for a short period of time, less than 10 seconds, and put the new valve up. When we started late 2010, early 2011, there are 20, 25 people in the room. This is Ian Serenbach, now retired. I'll come back to him, Tom Ivey, myself. I mean, this was really amazing. 1 in 4 people couldn't have this procedure because the catheters were too big. These are largely women with smaller arteries. And now through multiple generations, these have been miniaturized to the point where 95+% can be put in without a surgical incision. This was a very invasive procedure. In 1 in 4, we actually had to do a mini sternotomy, cut their chest or go through the apex of the heart. And this was barbaric. The explosion that you've seen in this technology and in this procedure is largely due to evolution in the procedure. Minimalist approach. 7 or 8 years ago, we stopped putting people in general anesthesia. 95% of conscious sedation, nurse anesthesia. I tell patients, it's like a colonoscopy. Really. I mean, nobody puts a tube in your throat. It actually takes about as much time as a colonoscopy now with the Edwards device. We got rid of the echo down the throat, used transthoracic and miniaturization of the technology. It's allowed us to go percutaneous. That means through the skin, put the valve in, come out, put a stitch in the artery through the skin, and 95+% of the time, patient has a Band-Aid. We rapidly ambulate up in the ward that evening. We actually have algorithms for same-day discharge, and there are clinical trials that have been published for this, but right now, 9 out of 10 go home the next day. The other, I think, explosion in this technology has been because every year for the last decade, there have been 2 to 3 new valves introduced into clinical practice or clinical research. And we have played a very active role in that. The first 21 millimeter Lotus valve in the world, the first Lotus Edge in the United States, which is what Boston Scientific took to market. We're done at Christ Hospital. First J valve in the United States, you'll see this in a second, for aortic insufficiency or regurgitation, leakiness of the aortic valve. One of the first 10 centers to do JenaValve, first 5 centers to do the HLT Meridian valve. You're going to see these in a second. And the top 5 enroller in Boston's NeoAccurate clinical trial. None of those valves I just mentioned, starting here, are currently FDA approved. The publication here is 2022. It's a couple months ago. The data ends in about 2018. This line continues to go up. This is number of transcatheter aortic valve replacements. This is surgical valve, which of course is dipped and somewhat plateaued. And this is mortality. Early on, that was a very invasive procedure in only the worst surgical candidates. We literally started in people that surgeons wouldn't touch. And now the mortality is down to less than 1% to 30 days. In the most recent clinical trial that we put the first patient in, there's 1,000 patients. This is for the SAPIEN 3 device, which is currently the market share leader in the US, in the world actually. 1,000 patients randomized between transcatheter aortic valve replacement from a transfemoral approach, femoral artery, with the S3 device, or surgery. In the same institutions, to 1 year, there was a 60% relative reduction in death, 60% relative reduction in stroke. And after 2 years, this remains highly statistically significant at 40% or more. So the data were really clear, even in low-risk patients. And this is 60 to 80% of what the surgeons were operating on. Transcatheter aortic valve replacement was here to stay. As far as length of stay, less than 2 days. There are very few things you do in medicine that give you this picture. Look carefully. This is overall in sex-stratified aortic stenosis-related death rates in the US over a decade. So in that decade, you see a dramatic reduction in death in men, women, combined, and it's temporally associated with the US FDA approval of transcatheter aortic valve replacement. There are very few things in medicine that do that. When I started in this, they said, you know, we project this for you business guys, this is going to be an $8 billion market. Then it's a $12 billion market. Let me tell you, it's not going to stop. It's going to be a $20 billion market. The data you've just seen have been generated with antiquated, empiric, and arbitrary guidelines. These are the Class 1 recommendations for replacing aortic valve 2021. At the top is 1A, symptomatic severe aortic, high gradient aortic valve stenosis. Now, I don't want to get in the weeds with you guys, but I'll tell you, what does that mean? That means, believe it or not, your insurance company may not even reimburse or won't pay for, we may cancel your procedure if your mean gradient is not over 40 millimeters and the peak velocity of blood through the valve is not at least 4 meters per second. I tell people it's like squeezing a garden hose. You squeeze it harder, more narrow, the water jet goes farther out. We actually can take the echo probe and get into that jet and measure the velocity. Excuse me. Now, the reason that's important is that's the guidelines that we use right now. But if you look at this, this is all-cause death on the left, cardiac death on the right. Then this is by decile distribution of mean gradient in 20,000 patients. Here's our guidelines, way over here. High mortality to 5 years, right? That's 5-year mortality. Chop it in half at 20 millimeters. There's a significant increase in mortality compared to not having aortic valve stenosis. Same thing with velocity. Our guidelines out here. This is 5-year mortality with a 4 meter or greater. What about 3 to 3.99? You guys can see this. It's not much difference in 5-year. Thank you very much. I really haven't had to talk this much in a while, so this is great. there's not much difference in the mortality to 5 years. That's why this game's going to change. This is the Progress trial. We're one of the first 10 centers up in the U.S. Progress is going to enroll patients with moderate aortic stenosis, a velocity of greater than 3, less than 4, gradients greater than 20, less than 40. This will rewrite the guidelines. If I ask one of you to be enrolled, you're randomized. So half of them get current guideline-driven care. That means see you in the office every 3 to 4 months. You let me know if you get short of breath, lightheadedness, get tightness in your chest. That is current guideline best care possible. The other half gets transcatheter aortic valve replacement sooner. We're going to follow these people out to 10 years. And the question is, are we going to rewrite the guidelines? We think so. We think that the guidelines as they currently exist, I make a joke, it's not Moses or Abraham coming down from the mountain with the slate tablets. It's a bunch of guys like myself sitting around in a room and saying, where should we draw the line? That's the guideline. It's a consensus guideline. And at the time, the only treatment we had was full sternotomy, open heart surgery. So you had to be sick to get that treatment. Well, times have changed, and guidelines will change. They will move upstream, trust me. And so that market is going to continue to grow for aortic stenosis. The other reason it's going to grow is here. This is aortic regurgitation or leakiness. This is a, unmet need, 20 to 30% of surgical aortic valve replacements in the U.S. today is due to leaky valve, not narrowed valve. These are different. There's not much calcium here. You can see this is calcified, this is not. They tend to have dilated root. Now, you can't even see the target here. I mean, you can't see where you're putting the valve because it doesn't light up on the fluoroscope. There's nothing to grip onto or anchor with the currently available devices. This increases your risk of, we call it migration, embolization. It's a big problem when the valve doesn't go where you want it to go and it falls out into the aorta. There's also a greater risk of leaking around the valve. This is another big market. And the valves that are being developed for treating aortic regurgitation, which some of you may have, they tend to have landing apparatus. We did the first J valve in the United States. These are anchor rings. You see these things come out like a lunar landing module. You can actually see these hit the leaflets, and they kind of dance on the leaflets as you put it in. So you can see and feel where you are, even if you can't see the valve. It has sinus cutouts, these little cutouts that are very physiologic for washout, and it makes getting at the coronary arteries very easy. This is an 85-year-old guy with heart failure. You can see the anchor ring out here. And we've done patients from Detroit to Atlanta with this. This is JenaValve, first 10 centers in the U.S. It doesn't have anchor rings. It has these little locators. This is the only valve that you can really carefully rotate. If it's not perfect, you raise it up, you rotate it, you drop it back down, and this assures that you're perfectly lined up. You'll see that here. This is each one of the locators. I'm putting some contrast. This is transesophageal echo. This is how the device knows where to go. It tracks this wire. Now, this is actually a Watchman device. Some of you may have this. This is in patients with atrial fibrillation. You'll hear that term a lot. Well, maybe next time we can talk about Watchman. We're going to deploy this. It's self-expanding. The valve is in. We take the catheter out. We suture the artery. We put a Band-Aid, and the patient can go home the next day. This is a very interesting device that we were first 5 centers in the world to put in. This is single operator, HLT, heart leaflet technology. Has a battery pack, excuse me. And if you don't like where it is, you can reposition, push the go button, it goes out. And if you like it, you push the go button a second time, and it everts the valve in a nitinol frame. As we go forward, the biggest challenge is going to be valve durability and coronary access, not stroke, not heart block. You're going to have specially treated valves, just like they do now in pig and cow valves. These are to prevent calcification and get them to last longer than 10 or 15 years. Think about putting those in 50-year-olds or 60-year-olds. You're absolutely guaranteed you're going to get another valve. Mechanical valves are there, but they require oral anticoagulation. And we wrote the early feasibility for this valve. You're going to see polymer valves. This is a silicone polyurethane urea polymer. Looks like plastic, has a durability of metal. It'll go 40 years on the bench, doesn't require oral anticoagulation, and it can accommodate TAVR should this ever need to be done. We wrote this up in December. The mitral valve, in fact, maybe I'll go through that quickly and get to heart failure. What I was going to show you is MitraClip. Many of you have heard of that, and you'll see it in a second. It's a clip to treat mitral regurgitation or leaky mitral valve without open heart surgery. And we use that predominantly in patients with heart failure. This is the big ticket item, guys. This is almost 9 million Americans. From the time of diagnosis to 1 year, 20% die, 5 years, 50% die. Number one, Medicare discharge diagnosis. We applied technology and innovation. 17 years ago, we opened a first-of-its-kind unit in the state of Ohio. This was the Carl and Edyth Lindner Heart Failure Treatment Center, and it was totally dedicated, 28 beds, inpatient, dedicated to the care of heart failure. Every day, a board-certified cardiology heart failure specialist, nurse practitioner, pharmacist, exercise physiologist, dietitian, round on these patients. This has allowed us to have the lowest readmission rate to 30 days of any center in the region, and to have the best clinical outcomes in heart failure. No matter what you do, though, this is what it looks like. This is survival, okay? There's an inexorable progression in heart failure. And many of you are affected by this, I get it, but this is the trend downward. We attack these patients with guideline-driven medical care and focused expertise. These are nurse practitioners, dedicated physicians. We have 6 full-time heart failure specialists in the group. We then use devices like MitraClip, which we are the #1 center in the state of Ohio for repairing the mitral valve with a clip. Pressure sensors we can put in the pulmonary artery. We can tell 2 days before you get short of breath that you're going to get short of breath, and that's very helpful if we adjust the medications proactively. And finally, whether you like it or not, you're going to look at left ventricular assist device or transplant. In between there, we've got 4 or 5 new technologies, which are really cool, that include shunts in the atrium, devices to tuck the mitral valve together, and even a device to shrink the ventricle. When you look at a big heart, it's not a good thing. Excuse me. This is the heart size getting larger. This is survival getting lower. So we can actually predict your 5-year survival based on heart size. So what do we do about it? Believe it or not, we can actually shrink the heart size. We're one of the first 10 centers in the country. We're testing this device. We come up the femoral artery, across the aortic valve. This is the mitral valve apparatus. And we put a wire outside the cords. Here it looks like a parachute in the muscle. And then we put in a series of what look like fish hooks, like a staple gun with spacers. You may find this, and then watch on the right. You can see as you shrink the heart, the mitral valve comes back together. It's very easy to understand. This is like a parachute. If this ventricle gets big, it pulls these leaflets apart, and the valve leaks. So this is one way to bring it back together. This is one of our patients, the real patient. We've got a catheter in the ventricle. You can see we loop this wire around, out, down the aorta. You're going to see us stapling here. It's very tedious. I'm not sure this will go into major, I mean, if you've got to be really simple, we say sometimes idiot proof, I'm sorry, but to really get out there into practice, this will be a function of specialized centers. Look at the tuck right there. See the little fish hooks? And this is what we did. We have 41 patients submitted for publication right now. We shrunk the ventricle by 11 millimeters acutely. Quality of life out to 1 year is significantly increased. It's Kansas City Cardiomyopathy Questionnaire. Functional capacity, 6-minute walk, significantly increased. Ventricular volumes decrease. No matter what we do, and I'm going to end on heart transplant, and I'll make this quick, it's still a boom business in the U.S. And the problem is we're capped. This is listed through 2019. There are going to be 8,000 people listed. Less than 4,000 are going to get a heart. More than half the people on this list are going to die. And that's a problem. Ohio, you may not know this, is in the bottom 40% for people who get transplanted within a year of all states in the United States. Top 40% of people dying on the list. Didn't make that up. Who are the people dying on the list? 75% are between 35 and 64. Okay? The Medicare group is growing rapidly. And how do we treat them now? We've got left ventricular assist devices. You guys have all heard this term, LVAD. This is a sequence from first to most recent. You can see they've gotten miniaturized. Our survival rate to 1 year, we actually had the #1 LVAD program in the United States that did not have on-site transplant. So without the ability to do transplant, we did 41 LVADs in 2000. We're going past that number this year. We're actually a referral site, including Ohio State. We get patients. This is 1 year survival, and compared to the national average is the green line. 5-year survival compared to the national average, which is the blue line. This is Christ Hospital in red with 70% confidence intervals. And this is an incredible technology. We are working right now with several companies that have pulsatility. If you had walked up to Dick Cheney, he's being interviewed by Tim Russert on Meet the Press. You can remember when he had an LVAD, he's waiting for transplant. He had no pulse. It's very eerie. It's continuous flow, so you don't feel a pulse. The briefcase is a battery pack connected to his drive line that you're going to see. That was the power source keeping him alive. Those things are a problem. We now have devices with pulsatility. That's how God makes us. You know, I think the organs, the vessels want to have pulse. And this is the first device that'll do that. We are waiting right now 2 patients at Christ Hospital. There are at least 2 at Cleveland Clinic. And once we are able to sterilize these devices, which is not consistent with the current state regulations for either Cleveland Clinic or us because it's state of Ohio, this device will go in at Christ Hospital. And it maintains pulsatility. It still has this problem. It's a drive line. You get daily dressing changes. I don't know how many of you know somebody that's had a left ventricular assist device. It's quite common. It's used either as a bridge to transplant because you're going to die before you can get a transplant, or if you're not a transplant candidate, this is your ticket. This is the next technology. We're working with these guys, Corvion, mobile charger. If you've got a late model car and you put your iPhone in a dish, you don't have to plug it in. That's exactly what's going to happen here.
Dr. Keriakes?
Yeah.
We're just coming to a close.
Yeah. Last 2 slides. Okay. This is the external power source. So these people will get charged remotely, like when they sleep. They won't have a drive line, and I think that's really impressive. And I'm going to close with artificial heart. This is really a viable technology. It doesn't require immunosuppression, and it does both sides of the heart, not just the left ventricle, because in the LVAD patients, the right ventricle tends to fail and is really a significant problem. This couples both ventricles. It gives you pulsatile flow. This looks like a person here on the arterial waveform. This is our new surgeon. It'll start in July. Put that device. This is actually the patient, so to speak, in Houston. And this is the future. And for the next 10 years, we think artificial hearts are probably going to be better than xenotransplantation. You all read about the genetically edited pig heart that Bartlett Griffith, University of Maryland, put in. Unfortunate gentleman died 2 months later because of a pig virus. And so I think this is going to be a reality also, but not in the next decade are we going to be doing that. So artificial hearts are there. And in conclusion, I think there's a tremendous pace of evolution in technology for catheter-based treatments for structural and valvular heart disease, heart failure, and atrial fib. These are really diseases of the new millennium, aging population. Focus, expertise, and technology in these areas are essential going forward. And I think centers that lead with innovation, technology, and clinical research will provide the most comprehensive leading cardiovascular care. Thanks, and I'm sorry for my voice.
Oh, thank you. Excellent presentation. Thank you very much. I think with your presentation, Dr. Keriakes, we can say this is phase 1, part 1, and perhaps if you would join us and come back again, we could do part 2, because we didn't get a chance to hear all of your presentation, which was dynamic, and didn't have time to ask questions. But thank you very much for your information on innovative technology, also with clinical research, putting into clinical practice. Let's give Dr. Keriakes another round of applause. With that, we will present you with a Rotary pin for this year's theme. Dr. Keriakes, it is Serve to Change Lives. Thank you. We will also, thank you. We will also give a donation to Rotary International for our efforts to the eradication of polio. We are down to just about 8 people in the world with polio now, coming down from, millions of people have been students, children have been vaccinated. So we will give a donation in your honor to the eradication of polio. We are about to close. Thank you so much for your patience. We will have a board meeting today in the Julep Room on the 3rd floor, and right after we dismiss, we will have the picture, Dr. Hux. We have a plaque to present to you, Ellen and Jack, in honor of Bob Bowling that has his name badge on it, and we'll be able to take pictures. So thank you very much for attending. Let's please go out and serve to change lives. And we look forward to seeing you here next week when we will have the Mayor of Cincinnati, Aftab Peer Review, as our guest speaker. Meeting adjourned.